Hello everyone, my name is Reagan Willis Varney. I am a current student at Walter State Community College. I am in the Occupational Therapy Assistant Program in Greenville, Tennessee. Today I will be presenting on the comparative effects of constraint-induced movement therapy, also known as CIMT, and neuromuscular electrical stimulation, also known as NMES, in stroke recovery. This presentation is based on an extensive review of evidence-based research. So to jump right into it, stroke is one of the leading causes of long-term disability, with many survivors experiencing significant impairments in motor function, more specifically in the upper extremities. These impairments can severely limit independence and quality of life. Occupational therapy plays a critical role in addressing these challenges by focusing on evidence-based interventions to promote motor recovery. Two widely used interventions, CIMT and NMES, have proven effective, but they serve different purposes. This presentation will evaluate these therapies and discuss how they can be applied in practice. The purpose of this literature review is to address the clinical question, in stroke survivors, what is the effect of constraint-induced movement therapy on improving motor function compared with neuromuscular electrical stimulation? My goal is to evaluate the strengths, limitations, and practical applications of each therapy to inform clinical decision-making. This helps occupational therapy practitioners choose the most appropriate interventions for their clients. Constraint-induced movement therapy promotes recovery by encouraging neuroplasticity through the forced use of the affected limb. So this involves restraining the unaffected limb, compelling the individual to rely on the weaker side. The benefits of constraint-induced movement therapy include long-term functional gains, improved dexterity, and increased strength. However, its success depends on active participation, making it more suited for individuals with moderate impairments. Research, such as systematic reviews and randomized control trials, strongly support its use in later stages of recovery for sustained motor improvements. I have attached a picture of what CIMT looks like in the lower right-hand corner of this slide. So as you can see, the left upper extremity is constrained, forcing the right upper extremity to be used while an individual is playing cards. On the other hand, neuromuscular electrical stimulation works by delivering electrical impulses directly to the affected muscles, stimulating them without requiring voluntary movement. This makes NMES especially beneficial in the early recovery stages or for individuals with severe impairments. It helps prevent muscle atrophy, it facilitates motor activation, and it lays the groundwork for future therapies such as constraint-induced movement therapy. However, the effectiveness of NMES can vary due to differences in stimulation protocols. Research highlights its utility in early-stage rehab when voluntary movement is minimal. I have also attached a picture of what NMES looks like in the lower right-hand screen. I do want to touch on very quickly the difference between NMES and electrical stimulation because they do look extremely similar. So the key difference is the type of nerves they target. So neuromuscular electrical stimulation specifically stimulates motor nerves, which control muscle contractions. So by targeting these nerves, NMES activates muscles directly, leading to visible and functional contractions. E-stim, on the other hand, either targets sensory nerves or motor nerves, more likely sensory nerves. So for example, TENS, one of the most common forms of E-stim, stimulates sensory nerves to block pain signals, which is why it's widely used for pain management. So the comparison of CIMT and NMES. When we compare the two therapies, CIMT stands out for its long-term neuroplasticity benefits, which are ideal for chronic recovery. On the other hand, NMES is more effective for quick muscle reactivation and early-stage motor recovery. These therapies are complementary, so NMES excels in the acute phase of recovery, while CIMT is better suited for later stages. So combining CIMT and NMES. Studies suggest that combining CIMT and NMES can maximize recovery outcomes, so NMES can be used to activate muscles early, preparing clients for task-oriented CIMT in later stages. This dual approach addresses motor recovery comprehensively, adapting to the severity of impairments and the stage of rehab. So what does this mean for occupational therapy? In occupational therapy, tailoring interventions to individual client needs is paramount. For example, NMES may be prioritized during the acute phase of recovery for clients with severe impairments, focusing on muscle reactivation and atrophy prevention. And then as the client progresses, CIMT can be introduced to promote sustained neuroplastic changes and functional improvements. By combining these therapies, practitioners can enhance client-centered care and improve outcomes, ultimately promoting greater independence and quality of life. To conclude, CIMT and NMES are both effective in promoting motor recovery, but they serve distinct purposes. So CIMT is ideal for chronic recovery stages where neuroplasticity can be reinforced, while NMES is critical in the early stages for severe impairments. So using these therapies together allows us to provide a comprehensive, stage-based approach to rehabilitation. This evidence highlights the importance of integrating both methods into clinical practice to address the unique needs of stroke survivors. I have attached a photo of my literature review presentation poster. This goes into a little bit more detail, and you can read on this if you so choose. And I would be happy to share this with you if need be. And then again, everything in my presentation that you heard here today and in my poster is backed by evidence-based research. Thank you so much.